We get CAT scans at baseline and every 8 to 9 weeks.
The major one that I think affects providers really quite deeply, as well as patients, ILD and pneumonitis. What's your strategy for monitoring patients on therapy?
With CAT scans. So when a patient is treated with T-DXd, we get CAT scans at baseline and every 8 to 9 weeks. That's my frequency. And I'm not only looking at response, but also looking for evidence of pneumonitis on scans. Because if a patient is asymptomatic but has pneumonitis on scans, the recommendation is to hold T-DXd even for asymptomatic ILD and start steroids. So it's very valuable to monitor this with scans because that's an actionable finding.
Yeah, and I think this sort of management strategy is, I think, the most aggressive, I'll say, for all the other sort of side effects that we deal with, but so important to make sure that this is a safe therapy for our patients. Any other sort of side effects that kind of you find you have to deal with? You mentioned diarrhea, actually.
Yes, diarrhea can be seen with T-DXd. Loperamide tends to work well. And then also alopecia. The drug does cause alopecia. There's a question about cold caps. In general, we've not seen much efficacy with cold caps with T-DXd. At SABCS 2025, our group would be presenting results based on our experience with cold caps related to T-DXd, and essentially there was not much benefit with cold caps related to alopecia from T-DXd.
It's to that.
The Dana-Farber group also has a phase 2 trial, and I think their preliminary results are also very similar, that these cold caps don't work that well with ADCs. And part of this could be because the payload is released over time, unlike chemotherapy, and cold caps are only given for a fixed duration of time.
Out of the available ADCs we do have in the clinic, though, it seems that the alopecia with T-DXd is less, would you say?
As compared to SG, yes.
Okay, we talked about, weighing adverse events against efficacy when starting a patient in the first line. Do you feel that any of these adverse events really would sway you away from T-DXd in the first line?
Not necessarily, as long as you're ready to reduce the dose. You will have some patients who, when you start T-DXd, they start having this chronic nausea or fatigue, and you can have a question about, I just want to discontinue this drug. Before discontinuing, consider a dose reduction. 1 or 2 dose reductions. Often you'll see in clinical practice that once you reduce the dose, the patient experience gets better.
Is there a point where you would discontinue and switch to a maintenance trastuzumab-pertuzumab strategy?
After a few cycles, that's an open question. I would want to see some data from Demether. That looks good. That's certainly something to consider. Or if a patient is really struggling, like, chronic nausea or fatigue, and they've received at least 6 cycles of T-DXd, then I would feel comfortable switching to HP and then just monitoring them on HP with the understanding that if the disease increases, I can bring back T-DXd again.
It sounds like a great practical strategy while we wait for data.